Good afternoon, everyone, and thank you for joining us today for Lung Cancer Canada's Policy Forum on Diagnostic Delays in Biomarker Testing. My name is Dr. Stephanie Snow, and I'm a medical oncologist at the QE2 Health Sciences Center in Halifax. I also have the privilege of serving as the immediate past president of Lung Cancer Canada and is a long-standing member of our medical advisory committee, working alongside an extraordinary network of clinicians, researchers, advocates, and patient leaders to advance lung cancer care across Canada. Before we begin, I would like to acknowledge that the work of Lung Cancer Canada takes place on the traditional lands of many Indigenous nations, including the Mi'kmaq, the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. These lands are now home to diverse First Nations, Inuit, and Métis communities. This acknowledgement serves as a reminder of the need to ensure lung health resources and diagnostic innovations are accessible to all Canadians, especially Indigenous communities who we know continue to face systemic disparities in healthcare access and outcomes. Today's forum is part of Lung Cancer Canada's Policy Forum series, now in its second year. It was designed to advance our 5 advocacy and policy priorities. This is the first of 3 sessions for our 2025 program, which carries the theme, Bridging the Gap, Precision Medicine in Lung Cancer Diagnosis and Treatment. This year, our focus is on time to patient, examining the systemic delays that prevent lung cancer patients from moving quickly from diagnosis to treatment. Last year, one of our forums focused on lung cancer screening, a critical entry point in the patient journey, but screening is only one part of the solution. To truly improve outcomes, we must also strengthen detection and referral within primary care, while ensuring that the diagnostic infrastructure and biomarker testing capacity are all in place once a diagnosis is made. Only when screening, detection, diagnostics, and treatment readiness are aligned can we accelerate access to life-saving therapies and ensure patients receive the best care, the care that they need and deserve. Today's discussion will focus on the diagnostic pathway, particularly the delays that occur from primary care referral through imaging, pathology, and biomarker testing. Our objective is to identify solutions that will strengthen systems, standardize processes, and advance equity in lung cancer care across Canada. I want to acknowledge the diverse group of participants here today: clinicians, researchers, advocates, and patient leaders. Your collective expertise and perspectives are invaluable, and together we can move from identifying challenges to developing clear, actionable strategies that will improve outcomes and survival rates for Canadians living with lung cancer. I would like to take a moment before we start to thank our sponsors for today's program and the rest of our fall policy series. I'd like to highlight the support of Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Janssen, Merck, Pfizer, Regeneron, and Roche. It is now my pleasure to introduce Leah Marie Magrino Stephenson. She is the strategic lead of All.Can Canada, which is a national initiative of All.Can, which is an international multi-stakeholder initiative focused on improving efficacy and patient outcomes in cancer care. Motivated by her experience as a caregiver for her late mother, Leah has spent nearly 20 years working to strengthen Canadian healthcare systems, particularly for underserved communities. She has been instrumental in advancing initiatives such as the Declaration of Personal Health Data Rights in Canada and Peel's Diversity and Inclusion Charter, while leading national advocacy to make cancer care more equitable, efficient, and patient-centered. Leah will speak to the current and future states of cancer diagnosis in Canada, and I will now pass over to her to take it away.
Thank you so much, Dr. Snow. It is an absolute honor and pleasure to be here today. I'm going to share briefly with you some of the high-level results of All.Can Canada's mixed methods research on cancer diagnosis in Canada. ACC, as our short form is known, is focused on how Canadian healthcare systems can achieve earlier and more equitable cancer diagnoses, including, obviously, lung cancer diagnoses. So next slide, please. And you can take us right to there we go. Thank you, to the current state. So we tried to visually depict the current state of cancer diagnosis in Canada from the findings of our mixed methods research. And as you can see, the picture is somewhat bleak. And it's worth diving into. It's available on our website, so feel free to take some time with this picture. There's a lot in it. There are many challenges and instances of confusion, anxiety, lack of information, and repeated delays that have a significant impact on people and their loved ones. We focused our research on starting from the point of symptom presentation through to readiness for treatment. So from clinical diagnosis through therapeutic and pathological diagnosis and readiness for treatment. So that's what this current state is representing. So I'm going to start with what others have termed as the spaghetti map, sort of that messy maze in the center of the picture. And we found that there are 3 phases to the diagnostic trajectory that are part of this messy maze. So that first phase, it's called suspicion. And people are continually, this is when people are showing up with a symptom, like a chronic cough, for example. Maybe it's been going on for a couple of months. Then people continually face challenges during that suspicion phase of diagnosis as they try to have their symptoms or their concerns validated and appropriately investigated. They can be dismissed repeatedly, and so it can be months to years of time as people cycle between primary care, if they have it, or walk-in clinics or virtual primary care services. Sometimes they'll go to allied health or complementary therapists to address, the symptoms if they've already sort of been told that it's nothing and they're still trying to deal with the symptom. And then they'll sometimes go to emergency rooms as the symptoms are worsening and they're not being able to figure out what the heck is going on. And there are frequently misdiagnosis and incorrect and unnecessary prescriptions happening during this suspicion phase of the trajectory. Once that first referral is finally made for an investigation of a possible lung cancer or to rule out a possible lung cancer, the best way to characterize the current state of that investigation phase of cancer diagnosis is overwhelming. Time and again, people in our study used the word overwhelming to describe the multiple facilities, the labs, the providers, the specialists that they needed to navigate and on their own. The diagnosis phase, so that last phase where, okay, you've got the clinical diagnosis, it's lung cancer, and then you need to get through pathology and other testing before you're ready to have the discussion about what treatment options are you looking at. So for many people, that we interviewed, they often reached a specialized team at the point of clinical diagnosis, and they had a better experience at that point. However, if they're metastatic, whether they get comprehensive genetic testing or not is highly variable and unlikely, and pathology, the way pathology performs is also highly variable. And I know, it can take anywhere from a week to 2 months for people to get their results. And I'm sure that Dr. Sheffield and perhaps Filomena are going to discuss this part of the trajectory in a lot greater detail. It's also important to note that, as people have said to us, this isn't just a sort of messy maze, but it's also a game of snakes and ladders where, missed referral or the fax got lost. Okay, slip back over to primary care again and have to restart and re-refer back in. So there's a lot of instances where this is not a linear process of getting through this mess. People can be sliding back and forth and having to get re-referred back into the system repeatedly. Basically, the spaghetti map shows us what informational and service fragmentation results in: a confusing, knotted mess that requires people and their loved ones, if they have them at their side, to advocate their way through the mess, or they will get tangled in the net and they may not be diagnosed for years. Now I'm going to touch on the barbed wire. And so there are basically three types of barriers or harms that make up that barbed wire. It's portrayed as barbed wire because it hurts on both sides of the wire. These are factors that slow some people's entry into the system, and they can also harm those people once they enter the system, and sometimes knock them back out of it again with a great deal of mistrust. So they're not going to want to get back into it again anytime soon. So these barriers and harms are organized in sort of three categories: social and structural determinants of health, oppression or dismissal or lack of recognition of people's identities, and then cultural, generational, and other factors. Do you have a fixed address? Do you speak English well? Can you afford the travel, the parking, the medical supplies needed, even for things like colonoscopies? You know, colonoscopies aren't free. Medications, time off work, childcare. Do you live in a major urban center? Are you perceived as too young, too old? Are you a frequently stereotyped community member, maybe seen as automatically labeled as drug seeking, or your advocacy gets you labeled as being a difficult patient? Is your autism or your anxiety being blamed as the cause of all of your problems? Intersectionality means that these types of stigmatized identities layer up and make things worse for some people. So if you're a young Cree woman who identifies as two-spirit, you might have a number of different issues and stereotypes and other sort of harms that directed towards you as you're trying to navigate through healthcare. Do you come from a community like in some South Asian communities where cancer is seriously stigmatized, leading to terrible social outcomes within your community, even within your own family? Are you a residential school survivor or from a family suffering from intergenerational trauma, and your fear and your trauma is read as anger or as being a difficult patient? Are you from an older generation, uncomfortable with asking questions of authority figures? These are all different aspects of what that barbed wire looks like, and what slows people's entry even further into the diagnostic trajectory, into healthcare systems more broadly, and then often causes that harm and knocks them out again once they do try to seek support and care. Finally, let me just address briefly also the additional challenges for structurally underserved communities when it comes to this structural expectation of self-advocacy. As I said, to get through the mess, you need to advocate for yourself. It's what my mother used to call the squeaky wheel system of healthcare. So this relies on agency. It relies on the power to advocate for yourself or for your loved ones to do it with you. And the wherewithal to find out what you even need to be advocating for in the first place. So the structural expectation of self-advocacy is to me a symptom of the lack of a system, of the fragmentation that exists within our system. And it filters out more and more people who, for many reasons, cannot self-advocate. So if we could go to the next, next slide, and then the next one after that, thanks. I'm not going to spend any time on that one. If you go back just for a second to round, there we go. But just take a look. These are some direct quotes from different people with lived experiences from our different studies, where they were talking about their experiences during the diagnostic trajectory for their cancers. And we did include lung cancer patients as part of our studies. So now I'm going to touch on the future state. Yeah, if you could go to the next slide, please. Thank you so much. So we tried to, again, represent what were the themes coming out from all of our work in terms of what does a better future look like. And we tried to represent that in a kind of patient experience map. So everyone in Canada in an ideal future state or a better future state belongs to an interprofessional primary care team or primary healthcare team. And that team has supports for differential diagnosis and disease management. And there's a lot of different examples of what those supports can look like. They can be updated guidelines and referral pathways that are readily available at at the bedside through there's programs like the Global Health Pathways that provide that for folks. There can be algorithms that sensitively expand lung screening eligibility using really straightforward health information that most primary care providers would have available. There is expertise and capacity that can be enhanced within primary care through programs like Ontario's Best Care program, where they're bringing, for specialty sort of extra assistance in terms of COPD and lung cancer screening, diagnosis, management, for example. And these interprofessional primary healthcare teams will have clear, rapid referral mechanisms so that they can swiftly investigate for a possible cancer and any other serious condition. They also have easy access and they know how to use, and they use it regularly, things like the community resource locator that CCS has created, so that they're referring everyone who, as soon as you're saying, okay, we're going to investigate you for a possible lung cancer. I mean, distress enters into people's lives and their loved ones' lives often right at that point. And so ideally, they're able to let people know about groups like Lung Cancer Canada, culturally specific supports like Queering Cancer, the Olive Branch of Hope, as soon as that referral for investigation is happening and as soon as that distress begins in many people. There's a robust primary care team. A robust primary care team will also have things like social workers or mental health counselors that can provide some support for psychosocial as well. And at that point of referral, the primary care provider, they can explain what's going to happen next at a high level in the pathway, what they can expect, basically, what the patient can expect, because there is a pathway and it's been properly designed, and they can articulate, okay, this is what's going to happen next, and this is about how long you can expect it to take, etc. Once they're in for investigation through that rapid referral pathway, there's something like Alberta's thoracic oncology program in existence. So in the ATOP example, there is AI reviewing the imaging and flagging abnormal findings for specialist review, and then that they can automatically refer onwards for further investigation, notifying the primary care practitioner, but not having to go back and forth with primary care for primary care to send the referral in, et cetera. It's expedited. There is an interdisciplinary team that specializes in thoracic oncology that's undertaking that rapid investigation. And they have a navigator built into that team that's preparing the patient throughout and ensuring they don't fall through any cracks. Any psychosocial or fertility or financial questions that arise are addressed proactively by the team. The goal is to stage shift and diagnose more people at stages 1 or 2. However, for everyone who's metastatic, the 21st century medicine demands they learn about their genetic mutations during treatment planning to assess their therapeutic options. Our system needs the capacity to do this with turnaround times that ensure swift initiation of treatment. And I know that Dr. Sheffield and Filomena will dive into this more deeply. To make any of this possible, the system needs the data infrastructure for connected care that enables providers and decision makers to learn and improve. It needs the health and human resources capacity. It needs flexible integrated funding models that support bottom-up innovation and results. And it needs ongoing cultural humility training of all healthcare providers and decision makers, so we continue to dismantle the barbed wire that's preventing some of our community members from entering the system and then harming them once they do so. Finally, we need co-design at all levels of the system for diverse users to support effective and equitable solutions. Because what industry designs new products or services without assessing whether they work for the end users or not? Next slide, please. So I know we all want and we need quick technical fixes, but it's important to remember this quote, which came from one of our equity roundtables. Whether it's at the bedside, within the lab, trying to reform elements of our healthcare systems by working together with decision makers, trust, which is built through relationships and over time, is the bedrock for sustainable change. So thank you so much. And I look forward to hearing others' presentations and our conversations together.
Thank you so much, Leah. You just so elegantly described a very complex situation in which our patients are entering, and really set up how there's so many issues that face our patients with a new diagnosis of cancer. You really highlighted how early inefficiencies and lack of necessary resources in our system can set the stage for delays right across the diagnostic pathway, and that's a critical reminder of where these challenges begin. I'd like to remind those who are attending that we do have a question and answer box. So if there's questions that pop up into your mind that you'd like to have addressed by any of our panel members, please put them in when they come up. We will have some time where there's going to be a question and answer session towards the end. At that point, building on the stage that Leah has just set, it's my pleasure to introduce Dr. Shantanu Banerji. Dr. Banerji is going to be able to share a clinician's perspective on how diagnostics need to be integrated with treatment readiness to ensure that biomarker results are truly actionable for our patients with lung cancer. Dr. Banerji is a medical oncologist at CancerCare Manitoba, where his practice focuses on lung cancer and sarcoma. He serves as the director of precision oncology and advanced therapeutics. He's also one of the smartest guys I know. And his role there is to guide strategies to integrate companion diagnostics into cancer care. In addition, Dr. Banerji leads a research laboratory at the Paul Albertson Research Institute, where his work applies comprehensive genomic profiling to drive cancer discovery and improve treatment. So we're now going to hear Dr. Shantanu Banerji take us through the importance of integrating diagnostics with clinical readiness. Take it away, Shantanu.
Thank you very much, Stephanie, and thank you for the introduction and the invitation to participate today. We didn't have a chance among the panelists to share our slides before the talk, so there will be a bit of overlap, and I think you've had a wonderful introduction to some of the larger system challenges that we as physicians work in and we as a cancer community have to navigate in order to provide care. What I'd like to focus on today is a bit more from the clinical spectrum and clinical perspective of how some of these challenges directly impact our ability to care for our patients. My disclosures are listed above, and I'd like to acknowledge that I'm presenting from Treaty 1 territory in Winnipeg. And as an immigrant and settler on these lands, that I'm committed to a spirit of reconciliation in the work and interactions of my day-to-day profession and personal life. Next slide, please. So this is a very simplified slide, but in general, when a patient is diagnosed with lung cancer, and particularly stage 4 lung cancer, the critical decision that many of us are trying to make as clinicians delivering care is, are we going to offer treatment that is more focused on chemotherapy and or immunotherapy, or is the treatment going to be focused more on something called targeted therapy? And as many who have experienced the lung cancer field, for good or for bad, know that biomarkers make or play an important part in terms of this decision making. And it's not to say that one treatment is better than the other, but the key point to take away is that certain treatments are only effective in certain biomarker settings, and giving the wrong drug to the wrong patient has significant harms associated with that approach. And not only harms to the patient and their outcomes, but also harms to the system, because there's tremendous cost and resources associated with improper care that we just can't sustain. Next slide, please. And so a key element to this clinical decision-making, and I know this is not news to most of the people participating, is the need for biomarkers to inform our treatment decisions. And in terms of our profession as in oncology, for decades, we had maybe a handful of biomarkers across several types or all types of cancer. But in lung cancer alone, in just the last couple of decades, we've seen an explosion of not only biomarkers, but more importantly, drugs that are effective in the context of those biomarkers. And the cartoon on the bottom right sort of illustrates many of the drugs that have reached clinical formularies over the last few decades. On the pie chart on the left is one example cartoon. It's not necessarily the only example, and it's not necessarily applicable in the exact proportions to every jurisdiction in cancer, because based on the ethnicity, the immigration patterns of our local population, and other exposures to environmental and other factors, the various distribution of these mutations can be quite different. But the key point is that ultimately these mutations are tied to either treatments that are already funded in Canada, soon to be funded, or are in clinical trials. And this is a space that's rapidly changing. And some may look at this slide and say my colors are a little out of date, and that reflects how fast things are changing. Next slide, please. And so we know that there's treatment available, but what's actually happening in the real world setting? And this reflects a study led by my colleagues in the lower window there, Drs. David Daw and Rebecca Rittberg, who looked at population outcomes in Manitoba in the period of time listed there up to 2015. And the key points to take away after looking at over 3,000 patients with stage 4 lung cancer, non-small cell lung cancer, is that only 20% of patients with stage 4 disease actually get a chance to receive systemic therapy. And as you can appreciate from the curve on the right, it's only those patients who receive systemic therapy that benefit from treatment and improve their survival, whether it's, at least in that period of time, more chemotherapy-associated treatments, or as shown in blue, oral treatments that were tied to a specific targeted drug or mutated gene that really benefit from treatment. So what's happening with the other 80% of patients? Why aren't we as a community able to provide effective care to that large group of patients? And I think this is the answer to that question is multifactorial. And as Leah pointed out in her earlier presentation, she did a fantastic job of outlining some of those systemic barriers that come into play. Next slide, please. And this is sort of my simplified version of the diagram that Leah presented, in the sense that we know that patients who eventually come to see a practitioner with the diagnosis of lung cancer have often followed a very complex journey to get to the diagnosis. And while I've listed sort of the tail end of this diagnostic process as a relatively linear series of steps, we know that the early part of that journey, particularly from the onset of symptoms to ultimately getting the attention of a practitioner, can take time. And at least here in Manitoba, due to shortages of primary care physicians, another very frequently used pathway that many patients take to lead to a diagnosis of cancer, particularly lung cancer, is presentation with emergent issues through emergency and ultimately getting diagnosed in the hospital. And so one of the exercises that we've tried to do locally, next slide, please, is to really if you can put in the next animation here, is to really get a timestamp of what are the various delays in our system. And this is a project that was executed by Dr. Daniel Myers, who I'm pleased to say joined our faculty in Manitoba just weeks ago. He essentially took a year of patients that were seen in our outpatient clinics and essentially went through the exercise of looking at timestamps of various interactions with the health system on their journey to getting cancer treatment. So if you can just skip through these animations and jump to the next slide. So he looked at the initial scans, the biopsies, the pathology, and here's sort of the kind of quick summary of his benchmarking study, which is to say from sort of that first scan, and we didn't look at symptoms here as our benchmark because that's a bit more complicated in sort of a retrospective review, but we decided that we would use the first scan, whether it be a X-ray or a CT scan that suggested a suspicion of cancer. We used that as sort of the entry into this benchmarking exercise. And essentially, you can see that on average, it took more than 2 months from the initial suspicious image for that patient to see an oncologist. And one of the biggest delays that we can see in the system, and that was perfectly highlighted in Leah's presentation, is the time from that initial suspicion to actually getting a biopsy. And we know for many patients in the lung cancer journey that the true label of lung cancer often doesn't start till that biopsy is done and we have confirmation that histologically this is the disease we're dealing with. And that in itself can take 3 to 4 weeks to go through. And then the other big period of time, at least in our system here in Manitoba, and this might vary from region to region, but reflects what we see here locally, is that from when a referral is made to our cancer center, and typically at that point in time, the referral is made with the knowledge that this is at least the disease we're dealing with. But from going from that process to finally able to seeing an oncologist to discuss treatment options, now we're looking at another 3 to 4 weeks on average. Next slide, please. If you could just pull up all the animations here. Oops. Next slide. Perfect. And so when we look at sort of the patients that ultimately made it to our clinics to be considered for treatment. And again, this is different from the earlier data I presented, which is these are patients actually coming in to see the medical oncologist and having a treatment discussion with the medical oncologist. Not everyone diagnosed with stage 4 disease. But of the patients that actually come in to have the treatment discussion, a little over 1/3 of patients do not even receive treatment. And it's the remaining 2/3 of patients that ultimately get either appropriate targeted therapy or chemotherapy and or immunotherapy based on their molecular profile. And as you can see in the figure on the bottom left, it's those patients who receive treatment that benefit. So at least in this particular data set with not a long time of follow-up, we see that the average survival in that patient population is 18 months. And we compare this to the 1/3 of patients who didn't get treatment, where the average survival is about 4 months. And so what you can see is that if we go back to the earlier figure and say that on average it would take 4 months to see if we say it took an average of 2 months to see an oncologist from the initial image, and then the average survival from seeing the oncologist to unfortunately the patient passing away is another 2 months, that essentially half of the patient's life from that initial suspicion of cancer is spent waiting to see an oncologist. And so this is not a great system, and it doesn't respect any of the elements that Leah pointed out in terms of the social and the cultural and even the aspects of dignity that we want to respect for all the patients that come into our clinics. Next slide, please. And so what that really means is we as a system and as individual healthcare providers really have to think about how do we work on using the tools available to us to make this diagnostic journey more efficient so that more of our patients have an opportunity for treatment. And this may look different from different jurisdictions to different jurisdictions, but at least here in Manitoba, we're sort of contemplating mechanisms to make some of the processes more parallel rather than linear. And we're leveraging technology. Leah mentioned AI, among other tools, to sort of help in this process. And so just to really emphasize that we as clinicians working in the system really know that the system has to change, and that biomarker testing as part of the larger journey is really integral. And so how do we implement these biomarkers? And Dr. Sheffield, Brendan will be likely going into this in more detail. But next slide, please. But one of the things we really need to put in perspective here in Canada is that this has to happen relatively quickly. And as a system, we need to adopt quite quickly to be able to implement these changes around biomarker testing and drug approvals. And what's illustrated in this cartoon, and it's from an article that I'm honored to help co-author with many of the people on the call today, but it's just sort of an overview of the number of steps that are required in Canada to go from getting a drug that has perhaps shown the ability to improve outcomes in clinical trials to finally getting it reimbursed by individual provinces so that our patients can get regular access. And the reality in Canada is that the average time it takes to go through all of these steps, step 1 through step 4, is about 3 years. And it's 3 years because there's many of these steps are sequential, and there's lots of files that have to be reviewed. But as a cancer community, we don't sit around for 3 years waiting till the last step before we make any changes. In fact, many of us who work in the treatment field, and particularly those of us who work in the diagnostics and in the molecular field, are already thinking about what are the biomarkers that are tied into these drug approvals, what are the technologies available to assess those biomarkers, and then most importantly, how are we going to integrate those technologies into the larger healthcare process that you've heard so much about, so that our patients can access these treatments efficiently and in the most timely manner. So I'll end here. I hope you appreciate that this was just a quick overview of how how the treatment journey really impacts how the journey ultimately impacts the treatment decisions for the patients, and that ultimately reflects the outcomes that we're seeing with patients. And we're definitely not doing it perfectly, and we have a community of providers, administrators, patients, and industry providers that are really working hard to resolve many of these issues. Thank you.
Thank you, Dr. Banerji. I think you just did a great job of just showing us from a clinician's perspective how critical it is for us, each and every one of us, to examine our patient journeys that lead to the assessments with us in clinic, where we should be able to align biomarker testing with clinical decision making, but also the consequences for patients when that alignment is missing. To dive a little bit deeper now into the infrastructure side, I'd now like to bring in Dr. Brendan Sheffield. He's going to be able to speak to the essential role of pathology and lab systems in reducing diagnostic delays and ensuring standardized, timely results across provinces. Take it away, Brandon.
Right on. Thank you so much. If we could just transfer the slide control to perfect.
And actually, Brandon, I'm sorry. I was so excited to hear what you're going to say. I forgot to tell everyone who you were. So while we're getting that set up, I'll just tell quickly a little bit about your bio. I apologize for that. Dr. Sheffield, he's an anatomic and molecular pathologist, and he's the founder of the Advanced Diagnostics Division at William Osler Health System, where he currently leads the team there. He's also the Director for Molecular External Quality Assurance for CPQA, which is Canada's national pathology quality organization, and he's the Regional Lead for Mississauga Halton Health with CancerCare Ontario. He's got over 50 peer-reviewed publications and a recently published textbook on this topic of molecular pathology, and his work is focused on delivering biomarkers that enable precision cancer care in real-world practice. And I must say, I have learned so much from Brendan over the years, and again, I was so excited. Now everybody knows who it is that's speaking to us. So there you go. Now you can take it away, Brendan.
Right on. Thanks so much, Dr. Snow. That was awesome. And thanks, Lung Cancer Canada, for having me here today. As mentioned, I'm a pathologist. I'm your laboratory guy here to tell you a little bit about what goes on behind the scenes. And thanks for listening to this, because you know, we all have an idea of what going to the doctor is like. So a lot of us have had imaging scans before, been to a doctor's appointment, but very few of us really have a sense of what goes on behind the scenes in the laboratory, and it's a very important part of lung cancer care. So this is me at work. You know, you can see me in a little square in the corner of your screen too. I'm sitting in the same room, but that's reverse angle. And we sit at the microscope and we look at these, you can see on the screen on the left-hand side of the image, these little pink and blue dots. These are cells. They're either benign cells or tumor cells, and we try and give our clinicians, our surgeons, oncologists a sense of what is going on in terms of a diagnosis. And more recently in the lab space, we do extra tests for proteins or genetics. And if you focus your eyes really keenly there, you can see on the computer screen, we're looking at one of our patients' genetic code on the screen there. So we've heard a lot about, you know, the clinical aspect, the issues that patients are facing with delays. These are some of the stats that we tell our team in the laboratory, and that I like to keep front of mind when we're thinking about the care of a lung cancer patient. This is from Dave Stewart and colleagues in Ottawa, and I think there's a very powerful fact to keep in mind, that the death rate of untreated non-small cell lung cancer is about 4% per week. So every week a patient waits to get started on their treatment, there's a 4% chance that they will die or become too sick to receive treatment. In terms of introduction, this is another really great study from a colleague of mine, Charu Agarwal, down in the US. And here in this cohort, she's described two groups of patients. And you can see that the first group in the blue curve on top is doing quite well, with an average survival over 2 years, whereas the group on the bottom is doing quite poorly with an average survival of around 6 months. And if this was a therapy, if this was a treatment, we would pay top dollar to receive this for our patients. But the intervention here is just whether or not the patients had their biomarkers available when they first met their oncologists. So the group on top doing very well if biomarkers were available, and it didn't matter if they were favorable biomarkers like EGFR or ALK or versus P53 or KRAS, just any biomarkers, as long as they were available, the patients would follow this top survival curve. And if the biomarkers were not available when the patients met their oncologist, they would follow this bottom survival curve with much more dismal outcomes. So I practice in the Toronto area in Brampton, and you know, we've put together an advanced diagnostic service, and we feel like we're doing really well for our patients, getting our results on time, making sure they follow that top curve. But you know, from time to time, you hear stories from groups. This is from Kitchener. It's less than 100 kilometers away from our hospital in Brampton. And a recent report from their oncology group showed that only 20% of lung cancer patients had access to biomarkers when they first met their oncologists. That means 80% of patients were following that bottom curve from Charu Agarwal's study. So what are we going to do about this? I'm going to tell you now about an initiative from the CPQA. This is the Canadian Pathology Quality Assurance. We're a national group, and we try and ensure that biomarkers delivered to Canadian patients are of a high quality. Now, traditionally, we looked at IHC biomarkers. These are protein-based tests like estrogen receptor for breast cancer patients. But more recently, we've started to look into molecular-based testing. And here's the new algorithm that we developed to try and test how well hospitals and labs are doing at delivering these biomarker results. So we construct fake biopsy samples in the form of FFPE blocks, and we associate those with a clinical vignette describing a scenario where a patient and their oncologist might need urgent access to biomarker results. And we send these by FedEx to participating laboratories and testing sites all over the country. And we use FedEx tracking to determine when the packages were delivered. Each lab is asked to do whatever biomarker tests they deem necessary and to upload their final reports on each of the 3 cases to the CPQA website. The CPQA then anonymizes the reports and hands them out to an assessment team, which includes medical oncologists. The medical oncologists are then asked to prescribe a therapy to each patient based on the clinical vignette, as well as the biomarker report that was produced by each laboratory. CPQA then reviews those prescriptions and based on those assesses the laboratory's ability to guide the oncologist to the correct therapy and provides a feedback report to each of the laboratories. So I'm going to show you now the results that we obtained last year from the first exercise we ever did using this methodology in non-small cell lung cancer. And if you want to read more, you can find our full paper here at the Journal of Thoracic Oncology, Clinical and Research Reports. So this first graph is showing the turnaround time that each of the labs were able to follow. So on the y-axis there, we have 13 laboratories. These are all Canadian labs that participated in the study. Then across the x-axis, we have turnaround time measured in days. That's just regular days, including weekends. And the end of the blue bar indicates the total time that a lab would have taken to submit those 3 reports. And this ranged from 5 days. You can see the quickest lab there was lab 8, all the way up to 57 days. So the slowest lab taking more than 10 times what the fastest lab took to do the exact same thing. The dark blue bars that you see on the left-hand portion for some of these turnaround times, this is the time in between when FedEx dropped the case off at the hospital and when the laboratory was able to accession the case. So you can see that sometimes taking more than 10 days for the package to be delivered into the laboratory from the shipping and receiving department of the hospital. There's also thin black bars on each of these times. The thin black bar is the self-reported turnaround time of each of the testing sites. And interesting to note that almost every single site, whether they're the fastest or the slowest, thought that they were doing this much quicker than they actually were. And the third thing that I'll highlight here is there's this hashed line that you can see at 14 days. 14 days is the maximum allowable turnaround time for lung biomarkers in Canadian guidelines, in US guidelines, and in international guidelines. And only 2 laboratories in the country were able to meet that, Lab 8 and Lab 2. And if you look up at the top, I think that Lab 13 is probably meeting that. They exceeded by 1 day, but it took 1 day for that package to get from the hospital front door up to the laboratory. So just moving a little bit further into these results, here we're looking at the exact same labs, but now the labs are spread out over the x-axis, 1 through 13. And down the y-axis on that first table there, you can see the 3 cases. There was 1 case with an EGFR mutation, 1 case with a MET skipping mutation, and 1 case where the patient would need chemoimmunotherapy. And the colors each mean something. So the red square would mean that the lab got the results wrong. And every oncologist on the assessment committee prescribed the incorrect therapy as a result of that. The dark blue bars means that the labs got everything right and that all of the oncologists prescribed the correct therapy. And the light blue shading indicates that there was some heterogeneity in terms of what the oncologists were going to prescribe. And the number one reason for that, well, really there's two. One is the reporting clarity. And you can see on the next track down, there's additional squares. A dark blue square meant that all the oncologists could understand their molecular report very easily. But a light blue shading meant that some of the oncologists had difficulty understanding components of that. And then the final thing there is the turnaround time. That's the same data that we saw on the previous graph. And you can see here that many labs, even if they got the right answer, if you compare lab 1 and lab 2, for instance, lab 2 did everything correct and got their results out quickly within 14 days. Even though lab 1 was correct in their biomarker results, because they took over 1 month to deliver those, many oncologists prescribed a suboptimal therapy, and which would unfortunately lead to suboptimal outcomes for patients in that scenario. So we decided to take a deeper look at these 3 labs that were producing very excellent results and achieving very excellent turnaround times. It turns out that they use different gene sequencers, different panels, but the one thing that they had in common was that there was a single molecular pathologist at each of these sites producing a single report. And we started to call that integrated report. So when a lab was doing this, having a single molecular pathologist running the entire biomarker process, on average, the results were coming out much, much, much faster than when there were multiple reports coming out in a non-integrated fashion. So I'll show you a little bit about what that looks like. This is an example of an integrated report where we'd have an EGFR or an NGS result together with a PD-L1 result. So an oncologist could look at this piece of paper and make a treatment decision for this patient. And what you're not seeing here is down below, there'd be a signature from a pathologist. It's removed for confidentiality. In a non-integrated report, we'd see one report that was typically signed by a pathologist that would have morphology data. So biomarkers that were scored by looking under a microscope, things like PD-L1 or ALK-IHC. And then we'd have a second report that was typically signed by a genomic scientist that was obtained with more molecular methods. So things that were done by testing in a test tube and reading out results on a computer. It would then be up to the oncologist to synthesize these and really come up with a final treatment plan. And the oncologist would have to search out these 2 different reports that might be published in 2 different places. You can see here, even the different font on these two reports, which came from the same institution, indicate that they would have been produced by different computer systems. So the thinking is that a complex non-integrated report is indicative of a much more complex workflow, like the one described in this image, where pathologists might be giving some of the biomarkers, and then a scientist in a separate lab in a separate facility might be providing the rest of the biomarkers. It creates a lot of specimen movement and adds a lot of days to the turnaround time. Whereas when there's a single person who's able to do both the microscope work as well as that molecular work, it leads to a much more simplistic workflow and enables a very rapid turnaround time, which we know is more likely to get the patients onto that ideal therapy. So, one question that really came from this is who was signing out the reports? And it's something that a lot of patients don't realize, or even a lot of providers don't realize, is who is there behind the scenes in the laboratory. And I think an important question to ask is, do we have a molecular pathologist? Is it somebody who's been through medical school, who understands the patient journey, who is able to speak that language with the surgeons, with the oncologists, and who's done really extensive training in laboratory medicine, versus a molecular scientist who has a lot of experience with gene sequencers and similar methodologies, but really a lot of that experience is coming from a research background with very limited training in a clinical setting. So ultimately, we've heard from myself, but also the other speakers as well, that there are really big gaps and inequities in cancer treatment. For me, it's apparent almost every day that there are large gaps in biomarker quality, and these lead to further inequities for cancer treatment. And in my opinion, we do really need to continue these sort of exercises for external proficiency testing. These help point out where the gaps are, but also help keep our finger on the pulse of how things are going, and so help us monitor improvement, or if things are trending in the opposite direction, if there's areas that need help or more intervention, these will help let us know where we can apply our extra resources. And certainly, I think that there's a real need for molecular pathologists. We need to train these individuals in Canada, and we need to make a more supportive environment so that they can find jobs and be employed here in Canada. I think molecular pathologists are a tremendous resource that can really help enable precision medicine for our lung cancer patients. So thank you very much, and looking forward to discussing and answering your questions along with the other panelists.
Great. Thank you so much, Dr. Sheffield. You really did a great job of underscoring the importance of strengthening our lab and pathology infrastructure. Without that foundation, none of those advances that we heard from Dr. Banerji in the diagnostics or treatment can be truly realized along those principles of the right test for the right patient at the right time. To round out the discussion, I'd now like to turn to Filomena Servidio-Italiano, who brings the vital patient advocacy perspective, connecting evidence, policy, and lived experience to push for national standards and equitable access to timely diagnostics. Filomena is the president and CEO of the Colorectal Cancer Research and Action Network, CCRAN, which is a patient-focused organization dedicated to championing the health and well-being of Canadians touched by colorectal cancer, or truly any cancer, and those at risk. Inspired by her father's cancer journey, Filomena founded CCRAN in 2006, and she has since dedicated nearly 2 decades to supporting, educating, and advocating for patients and caregivers, working closely with healthcare professionals across the continuum of cancer care. And I've done some great projects with Filomena, and we continue to plan more for the future. She's contributed to national and international publications on biomarkers, colorectal cancer management, patient-reported outcomes, and comprehensive genomic profiling. And she's a leading voice in health technology assessment submissions, ensuring that the patient perspective is embedded across multiple tumor types. I like to joke with Filomena, she's the lady who takes all the stray cats of cancer in, and she will care for every patient and help put together an HTA submission for any cancer indication that comes up. Filomena's work truly reflects a deep commitment to reducing the burden of cancer in Canada and advancing more equitable, patient-centered access to innovation and care. So Filomena is now going to bring us through that cross-cancer advocacy perspective. Take it away, Filomena.
Thanks very much, Dr. Snow. I'm very grateful. So allow me to share my slides. Here we go. And I'm assuming that you can now see my slides, ladies and gentlemen. That is my hope. Is that correct, Michelle? I'm going to take that as a yes.
That is correct. Thank you.
Outstanding. So good afternoon, ladies and gentlemen. I'm so very grateful to the organizing committee for inviting me to participate today. In terms of a very ambitious agenda, which I'm going to be adhering to today, I'd like to speak to why we dedicated a mandate to advancing biomarker testing, identifying the patient-reported barriers and challenges to accessing biomarker testing, and comprehensive genomic profiling, or CGP, and then finally speak to the work we have been doing to try to bring awareness and improvement in the diagnostic space by working collaboratively with multiple patient groups, with a particular highlight on the CGP cost-benefit analysis study findings that were just recently generated. So why? Why dedicate a mandate to advancing biomarker testing? Everything we do at CRAN is inspired by patients and the challenges and barriers they experience throughout their journeys. And over the years, we have heard from patients such as Steve, appearing on the left, and Matthew on the right, both of whom are stage 4 colorectal cancer patients, and countless others, that biomarker testing results are not being delivered in a timely manner to help inform those very important clinical decisions. It took 2 months for Steve's biomarker testing results to become available. And as for Matthew, it took 5 months for his results to come back to help inform his treatment plan. Metastatic cancer patients have contacted us to relay the biomarker testing results are not being delivered by the time the patient meets with their treating oncologist for the first time to help inform those critically important treatment decisions, something which you all have been hearing now through our other panel sessions, through our other panel members. And this requires advocacy efforts on the part of the patient groups. So essentially, it's all about the patient who helps drive change. But soliciting change can be a tricky thing. As humans, we're often resistant to change, and this is one of the hurdles we are presented with in our advocacy work. So if we lean on some principles of change management for a moment here, we know that in order to elicit any kind of change, we first need to build an awareness of the issue, and then secondly, we need to build the desire to create that much needed change. Now, enhancing access to biomarker testing and thus precision medicines is a pretty complex multifactorial issue. And to make an impact, we need to have diverse stakeholders at the table. I, myself, and my colleagues are true believers in the power of collaboration. And by collaborating with and working with as many stakeholders, as many experts, as many patient groups as possible, I truly believe we can more effectively build that awareness and that desire that is required to solicit change. So what did we do? We created a rather robust mandate dedicated to advanced biomarker testing, education, and advocacy. We took a pan-tumor approach to this work because we believe that collectively we can be far more impactful than we would otherwise be if we were working in silos. And we did it through our Biomarkers Conference series that started in June 2023. Our work in this area aims to address the challenges and the barriers to timely biomarker testing access, and importantly, turnaround time. We analyze patient-reported feedback on biomarker testing access across multiple tumor types. We advocate for equitable access to advanced biomarker testing right across Canada, and we strive to achieve all of this by collaborating with our very important stakeholders, moving the needle forward, especially with our patient groups, with whom we have so much in common, such as Lung Cancer Canada. So stepping back briefly to provide some context, in June of 2023, we launched our inaugural Biomarkers Conference after having observed and documented a number of challenges and barriers to accessing timely molecular testing results and precision medicines across multiple tumor types in Canada. The 12 patient groups depicted on the screen there participated in the conference, and 15 tumor types were represented. Patient group experts shared the barriers and the challenges to accessing timely and equitable biomarker testing and results from the patient's perspectives. The top three were, not surprisingly, lack of timely access to testing and reporting of results, lack of patient education, and thirdly, intra and inter-provincial disparities in access. And when we published the conference outcomes, 8 recommendations were made by our experts, one of which was to implement reflex biomarker testing to ensure biomarker testing results are available by the time patients meet with their treating oncologist. This was truly important to us. Our second biomarkers conference, held in June of 2024, built on those recommendations by exploring 2 main factors contributing to the lack of timely and equitable access to biomarker testing and results. The first of which was fragmentation of care, and secondly, disparities in public funding among provinces and institutions. And the emphasis this time around was on access to CGP and liquid biopsy based on the results of a national patient caregiver survey we disseminated right across Canada, and this time across 24 tumor types. Our calls to action in our publication included improving access to publicly funded CGP for all patients with advanced and metastatic cancer, and developing and implementing national standards for the performance, the integration, the coordination, and the communication of biomarker testing. So once the June 2024 conference was completed, together with a medical oncologist and a patient, we met with ministries of health and key policy professionals in Alberta, Manitoba, Saskatchewan, Newfoundland, and Ontario to share the outcomes of the 2 conferences on behalf of our patient group partners, all of which resulted in some pretty meaningful meetings and thoughtful replies from the balance of the ministries, with whom we did not meet, who have acknowledged and appreciated our collaborative efforts. It's been I would say, a pretty successful start to the advocacy campaign, opening the door to allow us to build that awareness and desire for change of which I spoke to earlier. But I must share with you, ladies and gentlemen, that I was able to identify a missing link throughout those meetings, something that policymakers were looking for that I just couldn't provide at those meetings. That missing link was the economic piece to support the thoughtful consideration or the introduction of comprehensive genomic profiling into the cancer care landscape. And after many sleepless nights, I realized that missing piece to the puzzle could potentially assist us in our advocacy efforts. So the next step in our advocacy work was to lead a cost-benefit analysis study to support the implementation of CGP, potentially, as a standard of care for Canadian metastatic cancer patients. And while this may be somewhat ambitious, we truly believe that every health policy advancement must start with a bold and ambitious vision, and we were prepared to lead that charge. Our 2025 Biomarkers Conference programming focused on CGP and precision therapies with the goal of identifying opportunities for broader policy development and advocacy. And the CGP cost-benefit analysis study findings, which we led, were featured as the keynote presentation at this conference. And it was actually the most well-participated session at the conference. We were pleased to bring together 24 patient advocacy groups, including Lung Cancer Canada, alongside a diversity of clinicians, pathologists, researchers, policy professionals, and of course, the ever important patients and caregivers to discuss the future of genomic testing in the Canadian healthcare landscape. The outcomes of this event are currently being captured in a manuscript whose ensuing publication will absolutely be utilized as part of the evidence base for our collaborative advocacy campaign across tumor types. So let's talk a little bit about CRAN's CGP cost-benefit analysis study. 1 year ago, we commissioned the Conference Board of Canada. It's essentially a think tank who performs research and analyzes economic trends within the policy space to undertake a significant project with the support of a number of patient advocacy groups and sponsored by a number of our industry partners who are incidentally featured on the next slide. The work has modeled and analyzed the costs and benefits of introducing and implementing comprehensive genomic profiling as a standard of care for Canadian metastatic cancer patients across the top 5 cancers according to mortality: lung, colorectal, breast, pancreatic, and prostate, all from a societal perspective, offering key insights to shape future policy development. Now, we believe the implications to be far greater as we plan to extrapolate the findings for other tumor types as we forge ahead with our efforts. These are the wonderful patient groups who stand in solidarity with our vision for this research project and most certainly beyond. What served as the impetus for this work? As a patient-focused organization, the patient perspective drives everything we do, not just for CRAN, but for other patient groups. Metastatic cancer patients are exhausting standard of care therapies and are looking to access additional therapeutics to manage their disease, potentially, yes, through clinical trials, off-label use, but most believe it should be offered upfront to inform treatment decisions based on the identification of genomic drivers. And we truly strive to act upon the outcomes of our scientific events, which have called for improved access to CGP in the metastatic setting, which is why we felt compelled to lead this. And policymakers are seeking economic data to help inform policy development collectively with our patient group partners. This was an endeavor that had to be assumed, and to my knowledge, this type of study or data has not yet been generated in Canada, so we needed to move forward in generating a much required piece that can help move the needle forward. So, I am so pleased to report that study findings were indeed quite compelling and positive across all 5 tumor types. Findings demonstrate that there are cost savings and benefits to the use of CGP across the 5 metastatic tumor types, up to 3,440 life years gained and $180 million saved between a time horizon of 2025 and 2030. The cost-benefit analysis showed that widespread implementation of CGP for patients with metastatic cancer across those 5 tumor types can result in significant survival benefits for patients at decreased cost compared to the current standard of care. And costs are expected to further decrease and benefits further increase as CGP evolves through the identification of other actionable mutations, for example, while accelerating the increase in CGP's clinical utility for tumors wherein CGP is not currently cost effective. The study findings were positive across all 5 tumor types, as the slide clearly demonstrates. But looking specifically at lung cancer, we see the strongest economic case, as would be expected based on the sheer volume of individuals impacted by this disease in Canada. For the purposes of modeling, only metastatic non-small cell lung cancer was modeled because it accounts for the majority of cases, for approximately 85% of metastatic lung cancer cases, due to the heterogeneity and nuances of the other tumor subtypes and extensive lines of treatment. So In non-small cell lung cancer, 1,819 life years stand to be gained over that 6-year horizon between 2025 and 2030 if CGP were universally adopted versus the current assumptions on standard of care, which includes, I believe, a 50-50 mix of CGP and point mutational testing. This, my friends, is extremely encouraging and hopeful, and we believe this economic case is critical to advancing policy change. In looking at this slide, negative values highlighted in green indicate cost savings to the healthcare system. As you can see, depending on the type of gene panel utilized, if CGP were universally adopted for metastatic lung cancer, we see significant system-level savings. The societal contribution was measured through increased total income linked to improved survival. These values are underestimated as the modeling does not take into account the money the healthcare system saves by way of patients who are on their optimal therapy would be saving by fewer visits to the ER, for example, or fewer visits to the clinic. Not only could universal access to CGP save lives, but it could also save the healthcare system and our society resources. We can't possibly rest our laurels on what we have generated today. But this is a great start, and we, with our patient group partners, will continue with our national collaborative biomarker advocacy campaign to present these compelling findings to provincial ministries of health and decision makers across the country. We will do it with the assistance of medical oncologists, the Conference Board of Canada, who is far more qualified than I am to speak to this, and always with a patient representative. Together with our patient advocacy partners, we will call upon policy leaders to reduce turnaround time for biomarker testing and results across tumor types and provide equitable access to comprehensive genomic profiling for metastatic cancer patients in Canada. But our voice is stronger together. And on behalf of CRAN, I invite you to stand with us. Thank you, ladies and gentlemen, for your attention today. I'm very grateful to have been invited.
Thank you so much, Filomena, for underscoring how patient advocacy can really bring evidence, urgency, and lived experience together to push for national standards and equitable access. It's true that economic missing link is indeed key for us broaching our advocacy conversations with ministries of health, and that work has really provided that critical piece of evidence that was so very needed. Now we're going to transition to the last segment of today's session, our panel discussion. We've had a number of questions come up in the Q&A that all panel members have been answering as we go ahead. So at this point in time, I'm going to start off by asking a simple question to all of our panel members. And if possible, I'm going to encourage you to answer in less than 5 words. I'd like to hear from each panel member. From your perspective, what is the single most critical barrier in Canada's current diagnostic pathway, from first symptoms to biomarker testing, that prevents patients from accessing timely treatment? So try to just a really quick summary of what's the biggest issue that we face today. Filomena.
You say 5 words or 5 minutes?
Yeah.
5 words.
Okay, all right. The timing of biomarker testing ordering. How many words is that?
Perfect.
Right.
Shantanu.
Reluctance to innovate.
Great. Brandon.
I think it's a lack of communication between all the specialties.
Thank you. And Leah.
There are no intentionally designed pathways in each jurisdiction system. Let's design them.
Great. So that brings me to my next question, which is directly for you, Leah, because you've had this perspective, not just within our country, but also with the international aspect of your organization. What best practices have you seen, either here or globally, that can strengthen primary care and investigation of a possible lung cancer as the critical entry point into lung cancer care?
So I'm going to mention a few different national and international practices. For some of it, we don't have time. So for the national ones, some of them are available through our website as case studies. And I'll put a link into the chat for anyone who wants to check them out and learn more and share them as part of your ongoing advocacy efforts. So there are things like the Danish three-legged stool approach to designing more specific pathways from primary care and symptom presentation through to treatment, diagnosis and treatment. So in that model, they're basically looking from the perspective of primary care at the epidemiology of people's symptoms. And then how are you designing very specific intentional pathways for more rapid investigation for different types of symptoms? So that's one international model. The UK has done some work on, they developed a persistent cough pathway, which includes more rapid investigation of possible lung cancers. And they ran an entire national campaign once they developed that pathway and got it in the hands of family practice. They ran a national campaign for the public to say, hey, have you been coughing for longer than, I forget how long they cut it off at, a month? Go talk to your family physician. It could be other things, but it could be cancer. Ontario has developed quite a few models of team-based primary care, and they are expanding those currently. So there's a lot of examples within the Ontario ecosystem. It's certainly not to scale of team-based primary care and primary health care. That is promising. And there's also supports like the Best Care program that can get bolted on to primary care that maybe doesn't have the team. Maybe it's just a single practitioner, a family physician that can help them more. And then there's team-based investigation, that as I mentioned. So once you can have a pathway, you can go more rapid referral into that investigation phase. Then there's examples in Quebec, like the rapid investigation clinics. I mentioned Alberta's thoracic oncology program. Ontario had diagnostic assessment programs. So these are some Canadian examples. And then there are things like the Global Health Pathways tool, which provide up-to-date at the bedside on a computer, usable for family practice to know, to better be able to investigate symptoms based on international guidelines and know what the correct and referral processes are within their jurisdiction. So there are programs like this that already exist. They also help family practice better manage the conditions that as appropriate within their practice. And then there's different algorithms and AI. I won't mention them because I don't want to advertise for anybody, but they are doing things like sensitively expanding who can be screened with data that's readily available within primary care, like blood pressure and these sorts of things. So those are some of the practices. There's quite a bit that's happening. It's a matter of really learning and adapting in our own jurisdictions and then connecting the dots in a pathway. Yeah.
Amazing. Those are some really great examples that we've seen from other countries. So some great things to get our brains moving. Shantanu, I'd like to hear your thoughts and how can we better integrate biomarker testing into clinical workflows? So those consciously designed systems so that results are not only timely, but that they're also actionable at the point of treatment decision. We've just heard, for instance, today, Ontario formally announced that there is going to be a rapid access to some cancer drugs, but how do we make sure that we can see those kind of programs and the patients are getting the right drug for the right test at the right time?
Thanks. So part of it goes back to what Brendan just said, which is the communication. So we found it very helpful to take the reins off in terms of who can order testing. When a lot of biomarker programs started, they were very restrictive to the knowledge experts, and those were considered either the pathologists or the oncologist. We've opened it up to say the physicians involved in doing the biopsies, such as the radiologists or the respirologists in the context of lung cancer, if they know more, they have the clinical information in front of them. They often know what the stage of the patients is. Make sure that's communicated, and at the time of the initial biopsy, order the molecular testing at the same time, so that it's kicked off right from the beginning and doesn't have to go through a series of steps. It's really over time, just re-emphasizing that this is integral to care, that anyone involved in or potentially involved in the journey of a lung cancer patient is aware of the importance of molecular testing and knows about the processes that are in place. So that's talking to physicians who have direct patient contact. It's talking to providers who are involved on the laboratory side. Not every pathologist has expertise in molecular testing, so we also need to communicate with them the importance of the testing and make sure that it's part of their thought process on a day-to-day basis. And communication really plays an important role. Where we're lacking a bit is the innovation in the system through adoption of technologies and other tools that many of us are used to using on a day-to-day basis, but actually making that a part of medical care so that communication is ingrained into how the system works as to something that's sort of jimmy-rigged as we work through things.
Great. So carrying on along that theme, Brendan, I'd like to hear your opinion. If you just had, a magic genie in the bottle appear with your 3 wishes type of thing, what systemic investments or changes do you think are most urgently needed across Canada to modernize and standardize our testing and delivery of results across provinces?
I think that the landscape changes so frequently. And what our patients and their oncologists are asking for now will be totally different than what they're asking for a few years from now. And so I think the one thing that'll set us up for success forever is having good molecular professionals within the lab. So, when our doctors train for residency in laboratory medicine, things like implementing new tests, NGS interpretation, liquid biopsy, these are elements that aren't really included in residency training right now. So to me, I think incorporating new test development, molecular testing, and provision of biomarker tests into training of all laboratory physicians would be great. And then also having more Canadian-trained molecular pathologists and jobs for molecular pathologists, and making sure that that's really a standard of care that every cancer patient is afforded, to have a molecular professional looking after them from within the laboratory. And that way they can take care of things like liquid biopsy and NGS in today's day and age, and whatever futuristic proteomics or transcriptomics we're doing in the next decade.
That's a great answer. If there's any way that I could clone my molecular pathologist, the wonderful Dr. Michael Carter, I would love to have 5 of him. And so finally, Phil, I think that we've heard across the panel today, and also hopefully for myself as well, there's true enthusiasm, there's true hope for our advocacy and being able to move things forward and change things in the future. Hopefully some of that enthusiasm has been contagious, and I'm hoping that some of the people who joined our panel today might have felt a call to action. What advice would you have for somebody who really wants to get involved in advocacy to help join our quest to ensure that the promise of precision medicine, faster and more equitable access to diagnostics and treatments becomes a reality for all cancer types?
Oh, I love that question, because my first recommendation would be contact us. I meant what I said. We are unapologetically, overly passionate about working collaboratively, not only with patient groups, but with anyone who is interested in ensuring that precision medicine becomes a reality. So contact us so that we can work together, because working together, we will achieve so much more than we would otherwise achieve working in silos. And I do believe the public policy makers will hear us when we have one loud, resounding voice.
Thank you so much. And thank you to all our panel members and those who have attended today. I think this has been the start, a continuation of an incredibly important and insightful conversation. Today, we've really highlighted, I think, some key takeaways: the need to strengthen primary care pathways, modernize our lab and pathology infrastructure, ensure that the biomarker results are delivered quickly, but also that we have consciously and intelligently designed and engineered systems in which we function. Because we do know precision medicine can have a huge impact for our patients on a day-to-day basis. And so really this comes back to exactly why Lung Cancer Canada exists. We are the only Canadian charity that's focused exclusively on lung cancer, and our mission is to ensure that patients and families get the attention, support, and system change that they deserve, and we're so thrilled to work with other advocacy groups for our shared goals. Really, I'd like to again thank our sponsors as we're coming to the end of our time today that made today's policy forum and many of our other activities coming up to Lung Cancer Awareness Month and throughout the fall. Again, thanking Amgen, AstraZeneca, Boehringer Ingelheim, Bristol Myers Squibb, Daiichi Sankyo, Janssen, Merck, Pfizer, Regeneron, and Roche. Again, I want to encourage all of you to stay engaged with Lung Cancer Canada, and I really want to highlight the next 2 sessions in our 2025 Policy Forum series that are coming up on October the 28th and on November the 18th. Please also feel this to be a warm invitation to join our annual Faces of Lung Cancer briefing, which will be coming up the beginning of Lung Cancer Awareness Month on November the 6th. And we'd love to see you out either virtually or in person for our Evening of Hope, which will be on November the 23rd, 2025, and it gets better every year. Finally, feel free and welcome to download or order your comprehensive guide to lung cancer as a resource to use yourself or to share with patients, families, and colleagues. It's been freshly revamped within the past 12 months and is an excellent source of information about lung cancer. And I think that every patient should be given this as soon as there's even a suspicion or a diagnosis of lung cancer. In closing, I leave you with this call. Together, we can bridge the gap, ensuring that every Canadian has access to timely, equitable, and effective diagnostics and treatments that they not only need, but deserve. Thank you, everyone who's attended and participated, for being part of this critical dialogue and for everything you do to make a difference for those who are affected by lung cancer and those who love those patients. Have a great day, everybody.